I'm Dr. Jamie Koufman, and this is Dr. Koufman's Acid Reflux Hour. It's actually less than an hour. Normally, I speak on a topic for 15 minutes, and then after that, I answer questions that you've submitted here. The question for today's topic is what causes acid reflux? And I've been thinking about this for a week or two, and I realized that most of the time it's multifactorial. You know, you've gained a little weight, your job gets you home a little later, your kids are playing soccer, you're stopping for more fast food. So there usually is not one thing. And for many people, you have low-lying reflux that's already there, and then the straw that breaks the camel's back. And a lot of things like that. They trickle on, and boom, up they go. And same thing's true of businesses, divorces, all kinds of activities trickle along, and then all of a sudden they spike. So I think that for most people, it's a combination. It's interesting, when I think about sudden causes, and this is a topic that's going to be discussed a bunch today in the questions, I'll tell you my story, and you'll hear about postviral vagal neuropathy. About 40 years ago on Christmas, I was sick as a dog with the flu, and 3 days later, I had no voice. I examined myself, my left vocal cord was paralyzed. 2 days later, I was coughing almost continuously, and I had all the reflux symptoms except heartburn. So I was probably, 40 years old, never had a voice problem, never had a cough problem, never had a reflux problem until I got the flu. Well, you should know the vagus nerve, there was a 3-part article on the vagus nerve on my blog, and for all of you, you should please sign up for the blog and please use it for a resource. I've written those articles for you. Someone's asked about a hiatal hernia. Just type in hiatal hernia, and up will pop the article. So the vagus nerves live right under the lining, they come out of the skull base, right under the lining membrane of the throat, right behind where the tonsils are, it's inside. And it's susceptible to viral infections, and not all viral infections are surface viral infections. For example, a common one is Coxsackie virus, and it's not so nice, and it will attack a vagus nerve. So having a nerve attack that basically runs the respiratory system, the digestive system, and the cardiovascular system, it's not a surprise that there are some sequelae. And the most common one that's sudden onset is, as I've outlined, partial or complete paralysis of a vocal cord or both vocal cords, and there are very few respiratory and cardiovascular sudden onset, but reflux can be one of them. So if you have cardiac arrhythmias, you have other problems. So let's just limit ourselves to basically my area, which is reflux and respiratory reflux. So vagal neuropathy, usually a virus, can cause sudden onset reflux. We call it postviral vagal neuropathy. And I'm writing about that now, and it's going to be in the book Respiratory Reflux, which I hope will be out by year's end. There are other sudden causes. A patient came to see me and said she's capable of going on short flights without reflux, but she was recently on a 6-hour flight, and she got terrible reflux. So I said, well, where were you going? Where were you coming from? She said, oh, I'm coming back from 2 weeks of vacation in Italy. So I said to her, listen, it just popped up now, but it's been growing since you got there, started eating so late, and your diet probably wasn't so good, and you were overeating and the whole lot. So, and when you think about things like snoring, people may not have a lot of symptoms until they start snoring and have other symptoms, usually at the same time, postnasal drip, sensational lymphadenopathy. That takes 20 years. 20 years of, listen, snore, S-N-O-R-R. When you go to my blog, type in snore, S-N-O-R-R. Supine, lying down, nocturnal, nighttime, respiratory reflux. And let me reiterate again, respiratory reflux is the newer, better term for LPR. I coined LPR in '87 because I didn't want to say GERD for my patients. But now anything. What about the sinuses? What about breathing? What about the ears? So respiratory reflux is the new, better term for what you probably have. And by the way, for everyone who has heartburn and indigestion, there are at least 10 people who have silent nocturnal respiratory reflux. So it's often brewing, and then it pops out. For some people, it's basically almost seasonal. They have a chronic cough following an upper respiratory infection. It takes weeks to months for it to go away, and then it goes away. Then they get another viral infection 6 months later, and it does the same thing. And this is a reflux-related cough, and it apparently requires some tipping over for the cough, for the onset of the cough. There are some other things that are interesting. I've seen a lot of patients in my life. I've estimated about 100,000. Most of what I know from them. For example, someone said, when I drink alkaline water, my heartburn goes away. We studied alkaline water. Some people said, when I chew gum, my reflux gets better. We studied gum chewing. Make more saliva, more bicarb, you swallow a lot more, it drives reflux away. So there are a lot of different precipitants of reflux, and the two that I find most interesting are people coming to me and saying, I never had reflux until I had my H. pylori treated. And I'd like to talk about that for a minute. We should stop looking for H. pylori. There's not a lot of evidence in my mind that H. pylori does anything. In fact, there is evidence that if you treat H. pylori, reflux gets worse. I mean, peer-reviewed science. So you shouldn't be looking for H. pylori. H. pylori caused duodenal ulcers. We stopped seeing them in the 50s and 60s. Who knows why? It was a big deal at the turn of the century, last one. So we just don't know. But treatment of H. pylori is an onset for people to say, that's when my reflux started. And interestingly, to go along with that, I've had a number of people over the years, and not a small number, say they never really had reflux until the GI did an endoscopy. So it's interesting that those are probably not the cause, but the tipping over precipitant for reflux. So if I'm going to talk about what causes reflux, a lot of things that you're worried about don't. For example, almost everybody has a 2-centimeter hiatal hernia. That doesn't cause reflux. Okay, doesn't need treatment, doesn't need surgery. Hiatal hernias are probably clinically insignificant. You can have a hernia without reflux and a reflux without a hernia, and we no longer believe that that's important. People also ask me about other precipitants, which are traumatic events, having surgery, having a death in the family, and all those things work through the vagus nerve. I'm writing about the vagus nerve now. And if you have a terrible event, the vagus controls your heart rate, your blood pressure, and if you faint, it's because of the emotion that basically is fed through the vagal nucleus. So the vagus really takes care of a lot of stuff. All of these precipitants are real, and most of them are, in my opinion, the straw that broke the camel's back. There was reflux going on, maybe postnasal drip, maybe a little throat clearing, maybe hoarseness in the morning, or mild chronic hoarseness. So again, I think most people have reflux, and then there was a takeoff point at some point, and that's usually just the straw that broke the camel's back. I do want to talk about specific things, and there are a whole lot of things that the lower esophageal sphincter is the connection between the esophagus and the stomach. And it is basically the main barrier against reflux. After all, if you eat something and it goes in the stomach, the valve closes, and it stays there, you don't have reflux. But if it opens, you have reflux. And by the way, belching is reflux. It means lower esophageal sphincter is opening and up comes air. So belching is reflux. So there are a lot of things that lower the lower esophageal sphincter pressure. That sounds funny. Decrease the pressure, making it more likely for reflux. And then you can add things. Let's say you've had something to eat. That lower esophageal pressure lower esophageal sphincter pressure, and then you go exercise, and you do some sit-ups, which increase intra-abdominal pressure, or some downward-facing dog, or many other bench presses, anything that increases the intra-abdominal pressure. So, of all the substances, beverages, if you will, alcohol is number one. When I've looked at over the course of my career, I treated people for reflux successfully, and life goes on. They beat their reflux. They're no longer refluxes. It's important. They do what they need to do to have modified their diet and lifestyle. They want to know, can they drink alcohol? And my experience is 50% of people who've beat their reflux can drink modestly without ill effect, meaning a recrudescence of reflux. But 50% of people, you have a cocktail, you're refluxing all night. You have a glass of wine, you're refluxing all night. So, for refluxes, alcohol is probably the number one trigger food. And you can add carbonated beverages, which have it's a double whammy. First, they increase pressure inside the stomach, but then they have an acidity in the same range as stomach acid. So, as you may know, it's pepsin that produces tissue inflammation, it's pepsin that causes cancer, it's pepsin that causes all the bad stuff, but it's activated by what? Acid. Pepsin is activated by acid. So there you are with pepsin in your throat, drinking acid to start it up and essentially facilitate the process of self-digestion. So carbonated beverages, and by the way, it's anything in a bottle or can. By law, everything is acidified. You've never heard of E. coli growing in a Coca-Cola. So carbonated beverages include fruit juices, energy drinks, and all of that. So then we get to coffee and tea. And people say, is low acid coffee better? I don't know what low acid coffee is. The problem in coffee has nothing to do with its acidity. It has to do with caffeine. The FDA says you can have 250 milligrams of caffeine a day. For the refluxer, it's half of that. 1 cup of coffee is 90 milligrams black coffee of caffeine. 1 cup of black tea, such as English breakfast tea, is 40. I get up in the morning and have two cups of black tea. Interestingly, I was a long-time coffee drinker, and it started to bother my stomach. And one morning I got up, had my coffee, and went and threw up. So you should know that coffee is a trigger food, but it's usually the caffeine. Some people, and it's a small percentage, have coffee as a trigger food. And if you do, decaf will have the same effect. So there's your list. Alcohol, carbonated beverages, fruit juices, energy drinks, everything in a bottle or can, including salsa, and coffee and tea in excess, too much caffeine. So the foods, it's very interesting. I'm writing a book, and we've done some math, and we spend $1 trillion a year to get sick. So we didn't have, when I grew up, we didn't have an obesity epidemic. Nobody had sleep apnea. One kid had asthma. Diabetes was, again, relatively uncommon. So all of these, heart disease, all of these are basically the result of our diet. Americans, you all, 30% of your diet is fast food. I have not been in a McDonald's since 1980 something. So I don't eat fast food. I don't even bother to go and get the chicken, grilled chicken breast somewhere, or a salad. Even the salads have very high-fat, loaded dressings in many cases. So, it's convenient fast food, but it's going to be your reflux guarantee. Now, have a double cheeseburger with a little bacon, a side of fries, and a Coca-Cola, and especially if it's in the evening, you stand 100% chance of refluxing all night. All right, 99% chance of refluxing all night. So what you're asking to do is to reflux. And if you already have reflux and you have silent reflux, it basically is just another way of spurring the thing on. So fried food and fast food, we're going to put in the same category. I do want to talk about processed meats. There's been a lot of talk about processed meats. You know how processed meats are, right? And the World Health Organization classifies processed meats as simply as carcinogenic as smoking. So smoking and eating processed foods are at the same level in terms of their carcinogenic effect. Reflux. Anything that's high fat. If you're going to have a little bit of Parmesan on your pasta, that's one thing, but sitting and eating half a big triangle of brie, which is a high fat cheese, is probably not a good idea. High fat foods in general make the lower esophageal sphincter relax and also make the stomach emptying slower. And finally, there's chocolate. Chocolate, I've written, by the way, again and again and again, I say, please, 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 sign up for the blog, put your name in, you get a notification every Tuesday of what we've written that week, but you could type in a chocolate. It was a very, very popular article. We talked a little about chocolate and dogs in the bottom part of that article. But chocolate is a triple whammy sometimes. Milk chocolate's worse than dark chocolate. It contains theobromine. Theobromine is just a chemical that relaxes the lower esophageal sphincter. And so it also is high fat, and it also has caffeine, and that also makes the lower esophageal sphincter relax. So chocolate is probably a no-no for you if you're refluxing until you get your reflux under control. Pharmacologic substances, including medicines and supplements, on the top of the list for causing reflux. I wrote this article. It's on there. Just put in Ozempic, and it causes reflux. And some of them are worse than others. But Ozempic, which is the most popular one, causes more reflux than any of the other of the GLP-1s. So Ozempic is high on the list of medicines that cause reflux. And the other one that's high on the list is the most common group of blood pressure medicines used in America today. And those are ACE inhibitors. So if you're on losartan and you've got reflux and a cough or just reflux, you need to ask your doctor to put you on a blood pressure medicine that is not an ACE inhibitor, not even a relative of an ACE inhibitor. And I've had patients with reflux and cough, stop their ACE inhibitor and have everything go away. So it is a real factor, and it ought to be eliminated. In terms of the obvious, tobacco contains nicotine. A study was done probably 50 years ago that showed a reflux occurs with 85% of cigarettes smoked. Again, lower esophageal sphincter relaxation from nicotine. And here's one that will fool you. B-complex vitamins and chondroitin and glucosamine, the joint medicines, and the B-complex vitamins and most antibiotics will cause reflux. And the combination of reflux of medicine for an infection, say an antibiotic and a steroid given to you at an urgent care, means you're going to feel great for a few days, and then your reflux is going to come roaring back worse than it was before. Steroids should not be used every day. They should be used for very, very specific indications in a few individuals. So, I guess I should say about the antibiotics, I hate to say it, but the one that I recommend, I had big dental work done, and he said, you need an antibiotic. I said, fine, I'd like a Z-Pak. So my experience has been that this does not cause reflux, and it's the one that I recommend if somebody asks me. Obviously, the choice is the doctor's choice, but given a choice, I like a Z-Pak. And you only have to take it for 5 days. So without further ado, let's get to the big ones. Eating too late, too close to bedtime. If you eat at 8 o'clock and go to bed at 10:30, you reflux all night, every night, even if it's silent reflux. You can't snack too close to bed. If you want to do the worst thing you could possibly do, you come home at 11 o'clock, you eat your hamburger and the fries and the Coke, and then you want to have a little nightcap a little while later. So you have yourself a nice single malt scotch and you go to bed. That patient, you have a 100% chance of refluxing all night. I won't even say 99. So eating too close to bed is the number one risk factor along with alcohol. And furthermore, as time has passed, the evening meal has become the big refueling meal of the day for us. And it's often with alcohol, it's often with fancy food, particularly if you're entertaining or being entertained. Snacking after dinner, overeating, obesity, and exercising after eating. I've written a nice article on exercise. I recommend taking an alginate before you exercise and chewing gum or sucking on hard candy while. So I hope this is helpful to you. What I've done basically is list most of the things that relax the lower esophageal sphincter plus the lifestyle factors. But eating too close to bed is definitely number one, and alcohol number one on the other side. Now, I got longer than I wanted to be, so I'd like to address some of the questions that have been sent in this week. First of all, let me make a comment to you. I'm a little sad when I read some of the questions because there are a lot of questions about hiatal hernia. There's an article about hiatal hernia. Okay, small hiatal hernias are no clinical relevance, so you could just type in hiatal hernia. You could type in any number of things that you're interested in there are questions about. So this is from Pamela. She said, ever since I started, my acid reflux started, I've had chronic diarrhea. Now, to my way of thinking, I've not, looking back at my experience, I've not seen diarrhea as a consequence of reflux. However, it is one of the common side effects of proton pump inhibitors. So if you're on Nexium or Prilosec or omeprazole or pantoprazole or any of the proton pump inhibitors, it's the proton pump inhibitor. And I might mention another side effect which really gets missed, and that's abdominal pain. I had a young man who was in his 20s come to see me. He had gone to the hospital, he'd gone to an urgent care with abdominal pain, he'd had CT scans, MRIs, endoscopy, 2 days in the hospital, found nothing, came to see me, and I said, stop taking the Nexium. So, it's related probably to your PPI if you're on a PPI. Here's another hiatal hernia and a weak LES. So everybody should understand that reflux is sort of a vicious cycle going down. Whatever started, the lower valve is now inflamed, stiff, and swollen. It's not such a good valve anymore. You reflux more, and you get a little more, it's self-perpetuating. A little more inflammation, a little more in the esophagus. Esophagus gets lazy, people get food getting stuck and pills. And then finally the upper valve kicks out. And I've said this dozens of times, when you lie down, what's in your stomach is in your esophagus, is in your throat. So weak LES is expected and everyone has reflux. And that's why I talk about doing a reflux detox, and it's not just about diet. If you can stop the reflux 100% for a month, it should heal. So lower esophageal, and by the way, I've done manometry since manometry became available, the good stuff, high definition, and the only thing that's not very reliable is lower esophageal sphincter pressure. So, if your doctor said it's low, you can stick it down again and it'll be high. So we don't generally use that criteria. But you can assume your lower esophageal sphincter, is not its tip-top condition because you got reflux. So you got to stop it. I was listening to the Reflux Summit last night. It wasn't a summit. I wasn't on it. I was asked. One of the dietitians said almond milk causes LPR. It doesn't. They made it up. Because of added thickeners in gums, I drink a lot of that. So there's not a shred of evidence that almond milk, I get unsweetened. The original has sweetener. I personally have been drinking it for, I don't know, since it became easily available. It does not cause reflux. I'm sorry, that's Jan. Thank you. Next question is Roberta. When I sleep with a wedge, I wake up at the bottom of the bed. Will the same thing happen with an adjustable bed? Let's answer the first question. Take your wedge and put a pillow on it, so now it's higher. Now put 2 pillows by your side that you can sort of pull into yourself that stabilize you, and put a big one under your knees. If you do that and you have back problems, you need 2 more pillows. You need one under your butt and one in your lumbar area. On my bed I have 11 pillows. No 2 of them are the same size in terms of thickness and softness. And a light one, a small one goes under my hip if I'm going to sleep on the side, big one between my legs. So you need to be able to negotiate stability. Here's what I say. If you do a detox program, at the end of a detox program, you're tired of trying to sleep at 45 degrees. So leave everything else alone and come on down a little bit. And if you start to reflux again, then you need the bed that goes up and down. And so for many people, that's the first thing they put back. You can't just go back to, back to normal. No, after the detox program, you have to add one thing at a time. And wedges are probably not high enough, and putting bricks under your bed and so on don't work. What are your thoughts on guaifenesin for LPR? I didn't know guaifenesin was for LPR. I thought it was for mucus. So it doesn't have any effect on reflux to my knowledge. Dr. Jamie, what's the best medicine safe with no side effects for acid reflux? I'm taking omeprazole, okay? Omeprazole is the worst medicine. It's all about money. 25 million people taking them. Okay, the side effects are horrendous. Okay, including, by the way, cardiac sudden death, kidney problems, brain problems. It ought to be taken off the market. Nobody is cured by PPIs. Let me say that again. 0% of people cured reflux is cured by PPIs. If they have heartburn, you may make the heartburn go away, but the disease goes on unabated. And that's why long-term use of proton pump inhibitors is associated with an increased risk of esophageal cancer. So, I recently was online and I was reading about famotidine. Some woman from some magazine wrote a big article about famotidine. Apparently she went on the internet, she found anything anyone had ever said about it and said that's a side effect. So I went into peer-reviewed. If you want to get peer-reviewed data, go on PubMed, type in famotidine side effects. There aren't any. It's a safe, let me say this again, safest, most effective medicine in the world. Say it over and over. Safest, most effective medicine in the world. And interestingly, we used Zantac for years, which is ranitidine. Famotidine is 7 times more potent as an acid suppressor. It's great, 40 milligrams at night. It doesn't have any of the drug interactions that ranitidine had. And so I think it's the best medicine in the world. And so you're going to switch over. My switchover for you would be probably 20 milligrams in the morning when you first wake up, famotidine, 20 milligrams before your last meal, and then 40 milligrams before bed. And don't forget about the alginates. Read the article on alginates. And by the way, there's a relatively new article. It's just OTC, over the counter. And that'll talk about alkaline water and alginates and famotidine. And there's a whole article on famotidine. So again, I'm begging you to use the blog as a resource. Now this is a very tricky question. This is Emil. I've been on your diet for 2 months and I still have voice and throat pain and sometimes chest pain. Is this a vagus problem? I don't know. I would have to examine you, but voice use pain. So let's say you don't have reflux, you don't have chronic throat clearing, you don't have difficulty swallowing, you don't have a lump in the throat, you don't have shortness of breath, you don't have any, but you have voice use pain. That is a vagal nerve, that's a neurogenic symptom, and that needs to be treated. And the other two that I treat are burning throat, but I don't mean burning after you eat and you're having reflux, I mean burning all the time. I mean intense burning, might kill myself burning, neurogenic pain. And the last one is neurogenic cough, which is not a very common diagnosis, it's neurogenic cough. Those are the 3 things that I treat. And by the way, on the blog there's an article on, just type in neurogenic and how I treat them will pop right up. But I don't think it's so common. I'm writing a chapter on the vagus now, and I have a disclaimer, a warning. Everyone's going to read this and say that I have vagal nerve problems. And the answer is you don't. Fix your reflux and you're going to be fine, 95% of you. Last question, another hiatal hernia. No, hiatal hernia doesn't have any role unless it's huge. This is the last question, and I want to tell you, in a way, I'm not sufficiently educated to answer this question because I've not followed the literature. But I will tell you what I know about eosinophilic esophagitis. First of all, we don't know exactly why, or at least I don't think we do. When I was treating this and patients had it, what we did is we asked them to take steroid spray. There's several of them over the counter. You can use them for the nose or the throat for like asthma, and spray and swallow, spray and swallow for 2 months, and that's usually the end of the eosinophilic esophagitis. So anyway, I've covered a lot of material. I just think I'd like to close with, I always get questions about marginal things, about things that may make a marginal difference. How about DGL? And the answer is big things. If you're eating at 7 o'clock and going to bed at 10, no amount of DGL is going to do anything. If you're drinking 5 Diet Pepsis a day, no amount of anything is going to do anything. And so you need to take stock of what are your reflux symptoms. Oh, you've got findings of atelectasis in your lung, and your doctor's worried about taking a biopsy of that little nodule in your lung. That's time to get your reflux under control. So anyway, thank you very much, and sayonara.